throughout the gravity period. Okay, this starts as early as 5th week and continues in all the trimesters, and even after delivery, the it takes time to revert the changes that has occurred in pregnancy to its normal pre-pregnant state. The physiological values and requirements, as well as normal laboratory assessment parameters, they dynamically change. So we need to understand the changes so that we can identify whether it is normal or a result of pathological change. Okay. Now, starting with the cardiovascular changes, the anatomical changes that are specifically seen are demonstrated in this diagram. Okay, as you can see in this diagram, you can see the heart shadow and the lungs. Okay, the lines in blue show the condition in non-pregnant state. The blue lines represent the relations between the heart and thorax in the non-pregnant woman. So you can see this is the diaphragm. Okay, can you see the cursor, the arrow I am showing?
Yes, sir.
Yes, sir.
Okay, this blue colored line represent the non-pregnant state. Okay, this is the diaphragm and this is the cardiac shadow. And the black lines represent the change that occurs in pregnancy. In pregnancy, you can see the diaphragm have elevated, right? From here, the diaphragm has gone up. Similarly, the heart has been pushed upwards and it has been pushed slightly towards the left, right? This is the blue line shows the heart shadow in non-pregnant state, while in this black line represents the changes during pregnancy. Okay, you can see the heart, the cardiac silhouette has is apparently seem to enlarge and it has rotated slightly to the left. Okay, due to elevation of the diaphragm, heart is pushed upwards and outwards with slight rotation to the left. This is the main change. This is why the apex beat is shifted to the fourth intercostal space. Can anyone say where the apex beat lies in normal non-pregnant woman or in any adult person?
Fifth
Anyone?
intercostal space, 9 centimeter from the midline.
Which intercostal space?
Fifth.
Fifth, right. Fifth intercostal space, 9 centimeter from the midline. But in pregnancy, you can see it has gone up to the fourth intercostal space. Okay, it has risen by one intercostal space, and that is about 2.5 centimeter outside the mid-clavicular line. Furthermore, the pregnant woman normally have some degree of benign pericardial effusion. Okay, there is some accumulation of fluid in the pericardial space. This is known as pericardial effusion, and this is normal. Okay, because of this increase in the pericardial fluid, we can see the size of the heart is increased during pregnancy. So this is a normal finding. If you come across any X-ray report of a person, of a pregnant lady, which shows increase in cardiac shadow, you have to take this in mind that this might be a normal phenomenon. Okay. Now let us go to the cardiac output. Cardiac output is a product of stroke volume and heart rate, right? So because of the increase in changes in the stroke volume and heart rate, you can find changes in the cardiac output as well. During normal pregnancy, mean arterial pressure and systemic vascular resistance decrease. Okay, the vascular resistance decrease because of the result of the effect of progesterone hormone. Okay, as all of you know that during pregnancy, you will find increase in the levels of estrogen and progesterone, right? This progesterone hormone is a muscle relaxant. Okay, that's why the muscles that are located in the different blood vessels, they get relaxed, so the vascular resistance decreases. Okay, so there is more amount of blood flow passing through the vessels. Similarly, there is changes in the blood volume and basal metabolic rate. Okay, as a result, cardiac output at rest when measured in lateral recumbent position increases significantly. Okay, you got this point. This is a very important change that occurs in pregnancy, that there is increase in cardiac output. Okay, cardiac output is increased as early as the 5th week of pregnancy. This reaches its peak to about 40 to 50% at about 30 to 34 weeks. So you can remember as 30 weeks as a reference. Okay, this is the time when the cardiac output is increased maximum during the pregnancy. Okay. I'm not taking into consideration the postpartum period. I'll show a graph where you can compare the cardiac output in different phases of pregnancy as well as the non-pregnant state. Okay, but it is during the 30 to 34 weeks of pregnancy that you will find a significant increase in cardiac output. This is the reason why the patients with heart diseases, okay, pregnant ladies with heart diseases, they show symptoms or become more symptomatic during this period. This is the time when the pregnant ladies with heart disease need to be vigilantly monitored. Okay. This cardiac output increases further during labor. So during labor, there is further increase in cardiac output, and immediately following delivery, this is the maximum that occurs. There is up to 70% rise in cardiac output over the pre-labor values. And after delivery, this cardiac output returns to normal state in pregnancy. However, to come back to the normal pre-pregnant state, that is in a condition when she was not pregnant, this takes about 4 weeks more. Okay. Now in this bar diagram, you can compare the cardiac output and the different phases or time of pregnancy and non-pregnant state. Okay, in the y-axis there is the cardiac output measured in liters per minute, and in the x-axis you can see non-pregnant state, different weeks of pregnancy, 20 to 24 weeks, 28 to 32 weeks, 38 to 40 weeks, and this is during the labor, early labor, late labor, and second stage of labor. And this is the immediate postpartum period. Now, when you compare the cardiac output in different phases of pregnancy and the non-pregnant state, you can easily say the maximum amount of cardiac output occurs in which phase? Anyone? In which phase of pregnancy or puerperium does the cardiac output reaches its maximum value? Are you seeing the slides?
We
It's in the immediate postpartum period. Okay, you can see that the cardiac output is 5 liters per minute in the non-pregnant state, right? This is the non-pregnant state. In pregnancy, in early pregnancy, you can see the cardiac output ranges from 6.8 to 5.8 liters per minute. However, during labor, the cardiac output progressively rises. Okay, in early labor it is 6.2 liters per minute. In the late labor it reaches to 7.2 liters per minute, and in the second stage it is 8.9 liters per minute. And in the immediate postpartum period, this is maximum at 9.3 liters per minute. Okay. And the cardiac output is lowest in the sitting or supine position. So there is positional variation of cardiac output. Okay, in sitting or supine position, the cardiac output is lowest and is highest in the right or left lateral and knee chest position. Okay, this finding we take into consideration while positioning the patients with heart diseases during labor. Okay, we ask the patient to lie in the left lateral or supine position depending upon the volume status of the patient. This increase in cardiac output is chiefly affected by increase in stroke volume and pulse rate. Okay, as you can tell, the cardiac output is a product of stroke volume and heart rate. So when there is increase in stroke volume and there is increase in heart rate, cardiac output will resultantly increase. The resting pulse rate increases approximately 10 beats per minute during pregnancy. Okay, this is the rise in the heart rate or pulse rate that occurs during pregnancy. There is an increase of up to 10 beats per minute. And the plasma volume expansion, that is increase in volume, begins between 10 to, it is said 10 to 20 weeks, but it can start as early as 5th week of pregnancy. Now let us go to the changes in the heart sounds. Okay, many of the normal cardiac sounds are modified during pregnancy. Okay, there is a study done by Cotforth and MacDonald who has found several changes that occurs in a normal pregnancy. Like there is an exaggerated splitting of the first heart sound. Okay, the first heart sound is heard because of closure of the mitral and the tricuspid valves, right? There is splitting of the first heart sound, and there is increased loudness of both the components. Okay, this occurs normally in pregnancy. So if you hear the splitting of the first heart sound, you should take it normal. Similarly, there is no definite changes in the aortic and pulmonary elements of the second heart sound. The second heart sound is because of closure of the aortic and the pulmonary valves. There is no change in that. So there is only splitting of the first heart sound, and sometimes the third heart sound may be heard in pregnancy. If you look at the murmurs that occur in 90% of the women, there is the presence of systolic murmur. The systolic murmur is because of increase in the cardiac output and the increase in blood volume. This is more intensified during inspiration, okay, and this is disappears shortly after delivery. The systolic murmur that you hear in pregnancy disappears shortly after delivery. In some cases, rarely you may also hear soft diastolic murmur. However, any diastolic murmur that is present in pregnancy should be evaluated with caution, because this may be a sign of the new heart disease that is developed in pregnancy, or the exaggeration of the previous heart disease that had already been present. Okay, in 10% of the patients, there may be presence of mammary murmur. Okay, this mammary murmur is because of increase in blood flow through the internal mammary vessels. Okay, there is increase in cardiac output. As a result, there is increase in blood flow through these vessels, and this increase in blood flow is heard as a mammary murmur. Okay, this is seen or heard in 10% of the pregnant patients. So, in summary, you can say that there is exaggerated splitting of the first heart sound, increased loudness of both components of the first heart sound. You may hear a third heart sound, and systolic murmur is common. However, if there is diastolic murmur, you have to evaluate the patient. And in 10% of the patients, you can also hear the mammary murmur. Okay, this is normal change that occurs in pregnancy. Now, let us go to the changes in blood pressure. Okay, blood pressure is a result of cardiac output and product of cardiac output and systemic vascular resistance, right? Now, you can say the cardiac output is increased. You have understood this. And what happens to the systemic vascular resistance? Anyone?
Decreased.
Decreases.
Yeah, systemic vascular resistance decreases. So one of the component is increased, another component is decreased. So the resultant BP also changes. However, as there is more decrease in systemic vascular resistance, there is decrease in blood pressure. Okay, increase in spite of large increase in cardiac output, the maternal blood pressure is decreased due to decrease in systemic vascular resistance, because the decrease is more higher in systemic vascular resistance compared to the cardiac output. As a result, the BP decreases. Okay, and the decrease in systemic vascular resistance is because of the smooth muscle relaxing effect of the progesterone hormone, as I had already told. Okay, there is overall decrease in diastolic blood pressure and mean arterial pressure by 5 to 10 millimeters of mercury. Okay, now if you look at the venous pressure can be measured in different veins. In the antecubital vein, the venous pressure remains unchanged in pregnancy. However, if you measure the femoral venous pressure, this femoral venous pressure steadily rises during pregnancy. This is mainly because of the compressing effect of the uterus. Okay, when the uterus enlarges, the gravity uterus is heavier. It compresses the blood vessels, major blood vessels like aorta and the inferior vena cava. Because of the compression of these major vessels, there is increase in venous pressure in the femoral veins. Okay, and because of the effect of progesterone, the veins are more relaxed, are more distensible, and because of the compression of the uterus on the vena cava, the veins in the lower limbs are more engorged. Okay, this leads to the development of varicose veins in pregnancy. So there is pedal edema, varicose veins, development of hemorrhoids or piles, and deep vein thrombosis because of stagnation. All of these are as a result of the changes in pregnancy. Okay, the physiological edema that occurs usually subside by rest alone. Okay, it doesn't need any treatment. Any pregnant lady with some levels of physiological edema is normal. That can be treated only with rest. Now there is a condition called supine hypotension syndrome, okay, also known as the postural hypotension. This occurs in 10% of women. It is a condition where the great vessels are compressed by the uterus. The vena cava and aorta are compressed by the uterus. This leads to significant arterial hypotension. Okay, so the patient may collapse or may feel dizzy. This is because of supine hypotension syndrome. Okay, this can also be demonstrated in patients with hemorrhage or spinal analgesia. any pregnant lady who receives spinal anesthesia, spinal block, or any pregnant lady who has had postpartum hemorrhage or antepartum hemorrhage because of the blood loss, there will be hypotension. Okay, similar hypotension occurs even normally in a pregnant lady. This is normal in 10% of patients. So this can be corrected by asking the patient to lie in the left lateral position so that the uterus is deviated to the other side and the compressing effect of the uterus is gone because of the change in position. Okay, this is supine hypotension syndrome. Now in this diagram, you can see the different levels of cardiac output consumed by different body parts. Okay, I just want you to focus on the uterus over here. Okay, the uterus is demonstrated by the blue color here. In a this is non-pregnant lady. In a non-pregnant lady, you can see that the cardiac output, 2% of the cardiac output is received by the uterus. Okay, uterus receives 2% of the cardiac output. And as the pregnancy progresses, you can see that the ratio of the cardiac output or the proportion of the cardiac output that is received by the organ gradually increases. Okay, in a non-pregnant lady, it is 2%. In the first trimester, it is 3%. In second trimester, it increases up to 10%. And in the third trimester, it is around 17%. Okay, so you can see that there is a gradual increase in the consumption of or the proportion of cardiac output that is used by the organ. Okay, so this increases from the uterine blood flow increases from 50 milliliter per minute to 750 milliliter per minute. Okay, similarly, pulmonary blood flow increases from 6 liter per minute to 8.5 liters per minute. There is increase. Even in renal blood flow, you can see there can be a gradual increase up to 1.2 liters per minute. There is the kidneys consume 20% of the cardiac output in non-pregnant lady and in the first trimester. However, in second and third trimester, it decreases up to 18%. Okay. However, there is a change in the cardiac output consumed by the kidneys. In this diagram, you can see the consumption of oxygen by different organs of the body. Okay, you can see that the oxygen consumption is gradually increased as the period of gestation increases. It increases from 12 to 13 milliliters per minute to up to 38 or 36 milliliters per minute at term. And this major increase is contributed mainly by the fetus and the placenta. You can see the graph goes parallelly upwards. Okay, till here, but in the placenta and fetus there is a marked increase. Okay, the oxygen consumption is mainly used by the fetus and the placenta. Now, the ECG changes that occur in normal pregnancy is not that much significant. There is only slight left axis deviation due to the altered heart position. Okay, as I have told earlier, the heart is shifted upwards and slightly towards the left and is liver rotated. Okay, that is rotated towards the left side. So because of this, there can be slight left axis deviation demonstrated in the ECG. In echocardiography, you can see increase in left ventricular and diastolic diameters. There is increase in the cardiac silhouette. This is because of increase in pericardial fluid. Okay, and it has been hypothesized that this increase in heart shadow might be because of physiological hypertrophy of the cardiac myocytes because of the pregnancy. However, this has not been proven. Okay. However, in echo, you will find that some level of increase in left ventricular and diastolic diameters, left and right atrial diameters are seen. There is increase in the size of these diameters. Now let us go to the respiratory changes in pregnancy. Due to the effect of the hormone estrogen, okay, in respiratory system, the effect is mainly because of the hormone estrogen. Estrogen leads to hyperemia, friability, and mucosal edema. This makes the glands in upper airway more secretory. Because of the increase in secretion, just a minute, okay? Hello? Okay, sorry, I had to take an important call. Okay, are you there?
Yes, sir.
Okay. So I was talking about changes in upper respiratory tract. There is hyperemia, friability, mucosal edema, and there is increased secretion of the glands present in the upper airway. Okay, and this is more pronounced in the third trimester. It's important to know about these changes because when a pregnant lady has to undergo any surgery, like cesarean section, or suppose the lady has appendicitis during the first or second trimester, what happens is if the patient has to be intubated because of these changes like mucosal edema, increased secretion, there is more chance of aspiration by the lady. Okay, there is more chance of difficult airway intubation. It may be very difficult to intubate the patient because of the increase in edema, because of increased secretion. There is more chance of aspiration by the patient. So once we know these changes, this makes us more careful regarding the procedure that we have to follow. Okay. Similarly, the patient may have a nasal obstruction. There may be epistaxis. Okay, because the vessels are engorged and it is more friable. And the patient may have sneezing episodes. There may be vocal changes, and all of these may worsen when the individual lies down. When the patient lies down, that is when she lies in a supine position, what happens is there is uh, increased in preload. Okay, there is increase in blood flow to the upper part of the body. This leads to increased edema, increased secretion, and there is more nasal obstruction. Okay, the patients may also develop nasal and sinusoidal polyps, and these tend to recur in women with each pregnancy. Okay, some of the pregnant patients may also have snoring because of the nasal obstruction, and they may also have obstructive sleep apnea. Okay. Now, I just discussed the clinical consequences of these anatomical changes. There is preferential mouth breathing by the uh, lady because of nasal obstruction, and there is intolerance of nasal cannula delivery of oxygen. So it's difficult to deliver oxygen through the nasal cannula. There is difficulty in inserting the NG tubes. There is difficulty in inserting the nasotracheal tubes, and these pregnant ladies, uh, they are very poorly tolerant to these procedures. And in pregnant ladies of a certain age, we have to use a smaller size endotracheal tubes, okay, because of these effects of edema. We have to use 6 or less size endotracheal tubes. In the lower airways, similar to the changes in the upper airway, there will be some mucosal changes. Okay, this is more prominent in the central portion of the airway, like larynx and trachea. There can be non-specific complaints of airway irritation, like irritant cough and sputum production. This is also normal. So a pregnant lady, if she has some dry cough and some sputum production, however, she has no fever, there is on auscultation, you will find no changes in any long shadow, I mean any sounds, then you have to take it as a normal finding. The physiological changes or causes of nasal mucosal changes appear to be predominantly mediated by the estrogen hormone. Okay, this what happens is estrogen causes the tissue to be more hydrated and have edema. Because of this, there is obstruction. They also cause capillary congestion and hyperplastic and hypersecretory mucous glands. Okay, this is the effect of estrogen that leads to all of these changes. Now, if you look at the respiratory muscles in the thoracic case, uh, as I had shown in the earlier slides, that there is rise of the diaphragm, right? So, because of the enlarging uterus, there is upward displacement of the diaphragm. This leads to increase in anterior posterior as well as the transverse diameter of the thoracic case. So, both AP and transverse diameter of the thoracic case is increased in pregnancy. The diaphragm may be elevated up to 4 centimeter upwards. Okay. However, the diaphragmatic function is not impaired. Okay. Now, in this diagram, if you can see, this is a non-pregnant state. This is a pregnant state. Okay. In a non-pregnant lady, you can see that the subcostal angle, the angle between the two costal cartilages, lower costal cartilages, is around 68 degree. Okay. And this is almost doubled in a pregnant lady. It is around 104 degree. Okay, you can see it's 103.5 in the diagram. So there is progressive relaxation of the ligamentous attachments of the ribs. This increase in the subcostal angle is because of relaxation of the ligaments. Okay, the ligaments that join the ribs to the sternum. These ligamentous attachments of the ribs broaden the subcostal angle by approximately 50%. So consequently, you can see that the diameter, the thoracic diameter is increased by 5 to 7 centimeter. So the chest circumference is increased by 5 to 7 centimeter, and the diameter is increased by 2 centimeter. Okay, the shortening and widening of the thoracic cavity results in upward and lateral displacement of the cardiac apex on the chest radiography. Okay, this I have already told you. You have understood. Now let us go to the pulmonary function. Okay, if you can recall from your basic science, there are different pulmonary functions like tidal volume, residual volume, okay, expiratory reserve volume, inspiratory reserve volume, functional residual capacity, vital capacity. Okay, all of uh, these lung volumes or lung functions have some changes during pregnancy. Mainly, there is there is increase in tidal volume. Okay, there is increase in tidal volume, and there is decrease in residual volume and functional residual capacity because of decrease in expiratory reserve volume. Can anyone recall what tidal volume is? Anyone?
500 ml.
Okay, 500 ml is the volume. You are very right. Okay, that's correct. What does it mean? I mean, what is tidal volume?
Effortless breathing गर्दाखेरि जति भोल्युम एक्सपायर र इन्सपायर हुन्छ
Okay, absolutely right. That's the volume of air that is inspired or expired during normal respiration, okay, without any effort. That's the tidal volume. In pregnancy, the tidal volume is increased. Okay, there is increase in tidal volume. And similarly, now you can, if you know the meaning of the residual volume and expiratory reserve volume, you can say what changes does this occur? Does occur in what changes occur in these volumes during pregnancy? From the anatomical changes I have just explained. Anyone? Okay, the diaphragm is shifted upwards. So if the diaphragm is shifted upwards, what happens? What happens to the residual volume and the expiratory reserve volume? They have to decrease, right? Because the space is same. The space that was present in a non-pregnant state that has been slightly reduced because of the shift of the diaphragm. Okay, so what happens is the functional residual capacity decreases slightly. The expiratory reserve volume decreases. Residual volume decreases. Okay, these are the main changes. Inspiratory capacity is a total of sum of tidal volume and inspiratory reserve volume, right? This increases slightly. Total lung capacity is either unchanged or slightly decreases. The respiratory rate is essentially unchanged. So the respiratory rate is almost same. Tidal volume and resting minute ventilation increase significantly as pregnancy advances. Okay, the minute ventilation is the product of tidal volume and respiratory rate, right? Respiratory rate remains same, but the tidal volume increases. So the minute ventilation increases. You understood me? Okay, also in the next slide as well. Okay, here you can compare the different lung volumes and the capacities of the lungs in a non-pregnant state and the pregnant state. Okay, this is the tidal volume. If you can see the arrow I am showing, this is the tidal volume. Okay, this is the tidal volume in a non-pregnant state. If you compare this tidal volume with the pregnant state, you can see that tidal volume is increased, right? VT stands here for tidal volume. So the tidal volume here in a non-pregnant state is lesser than that in pregnant state. So the tidal volume increases. If you see the residual volume, this is a non-pregnant state. This blue shadowed area, this represents the residual volume. Okay, and this represents the up to here. This represents the expiratory reserve volume. That is the excess amount of air that can be expired after normal respiration. Okay, that is the expiratory reserve volume. The sum of expiratory reserve volume and residual volume is the functional residual capacity. Okay, these are the main four changes that occur in pregnancy. Tidal volume is increased, expiratory reserve volume is slightly decreased, residual volume is decreased, You can see, you can compare the height of the graph over here. It is almost around 1.5 liters residual volume in non-pregnant state, while in pregnancy, it is around 1 liter. Right? So the residual volume decreases, expected reserve volume slightly decreases. As a result, the functional residual capacity decreases. Okay, see, you can see the functional residual capacity is around 2.2 liters, almost 2.2 liters in a pregnancy, while in non-pregnant state, it is around almost 3 liters. Right? So these are the 4 main changes that you have to remember. Okay, this may come as MCQ question. Okay, changes in lung volumes with pregnancy. The most significant changes are reduction in functional residual capacity and its subcomponents, which are the expected reserve volume and the residual volume, as well as increase in inspiratory capacity and tidal volume. Okay, tidal volume is increased here, and the inspiratory capacity is also increased. If you compare the inspiratory capacity in non-pregnant and the inspiratory capacity in the pregnant state, you can see there is increase in inspiratory capacity. This is because of increase in mainly because of increase in tidal volume. Okay. Okay, some scientists have studied the changes in pulmonary function in a singleton pregnancy and in twins. Okay, in ladies with singleton pregnancy and in ladies carrying twin babies. And they have found that there is no significant difference between the two groups. So the pulmonary function is almost always same in both the groups. Now let us go to the changes in acid-base equilibrium. Okay. An increased awareness of desire to breathe is common even early in pregnancy. Even in early pregnancy, there is increased awareness of desire to breathe. So this may be interpreted as dyspnea, right, or difficulty in breathing. Okay, and this may suggest pulmonary or cardiac abnormalities. But in fact, this is not present. Okay, this is normal. So this increased awareness of desire to breathe or increased desire to breathe is interpreted as dyspnea. However, this is not dyspnea, and this does not represent any pulmonary or any cardiac diseases. Okay, this physiological dyspnea is thought to result from increased tidal volume that lowers the partial pressure of carbon dioxide in the blood. Okay, and this increased respiratory effort during pregnancy, and in turn, reduction in partial pressure of carbon dioxide is likely induced in large part by the hormone progesterone, and to a lesser degree by the hormone estrogen. So the main hormone that leads to this acid-base equilibrium changes or a change of feeling of dyspnea is the hormone progesterone. Okay, that is the main culprit. Now this slide shows the summary of different respiratory changes that occur in pregnancy. In the lung volumes, you can see that the total lung capacity is almost unchanged. Vital capacity is almost unchanged. Inspiratory capacity is slightly increased, and functional residual capacity decreased. Residual volume is decreased. Expiratory reserve volume is decreased. Okay. And if you look at the chest wall or lung mechanics, the chest wall compliance is decreased. The thoracic diameter is increased. Okay, this is increased by up to 2 centimeters. Diaphragm is elevated upwards, and the lung compliance is unchanged. It is only the chest wall compliance that decreases. However, in pregnancy, there is no any changes in the spirometry. Okay, first FEV1, FVC, FEV1 FVC ratio, these are all unchanged. The main importance of these spirometry findings is in identifying patients with COPD or asthma. Okay, in these patients, the FEV1 FVC ratio changes. However, in pregnancy, there is no any changes in these spirometry findings. So the assessment of spirometry findings is almost same as in non-pregnant state. Okay, how you interpret the spirometry findings in non-pregnant ladies is almost same in pregnant ladies as well, because there is no changes in any spirometry findings. Okay, and regarding ventilation, the minute ventilation is increased, as I have told already, because there is increase in tidal volume. However, the respiratory rate is unchanged. In the blood gas, there is slightly increase in pH. Okay, this ranges between 7.4 to 7.45. There is partial pressure of oxygen increase slightly. PaCO2 is decreased, and bicarbonate is slightly decreased. Okay, these are the changes that occur in the acid-base equilibrium. Okay, so this is about the changes in respiratory and